Okay, so endometriosis, it's a pretty high yield topic with a decent amount to know. Stick around till the end because I have a mnemonic that'll help you remember all of the high yield points. Quick thank you to everybody who sent a nice comment, bought a t-shirt, a mug, supported the channel in any way. I really do appreciate it. You all are so nice. So thank you again for that. And a quick heads up, some people have been asking me if there's any way to access the PowerPoint slides. I don't have a way yet, but I did just make a Patreon page where I believe I can upload all of those. So that should be available shortly. And I'll leave a link in the show notes once it is. So let's talk about endometriosis. What is endometriosis? Well, endometriosis is a condition where endometrial tissue, glands, and stroma are occurring outside of the uterine cavity. So quick refresher, the uterus, as we know, is a hollow muscular organ located in the pelvis between the bladder and rectum. It has a number of functions related to reproduction, menses, implantation, gestation, labor and delivery, etc. Now, the wall of the uterus, importantly, has three layers. The perimetrium or serosa, which is the thin outer layer that envelops the uterus, the myometrium, which is composed of smooth muscle cells, and then the layer we're concerned with today, the endometrium, the inner mucosal layer that lines the inside of the uterus, and the layer that responds to cyclic ovarian hormone changes, thickening and sloughing off each month during menstruation. So now that we know what endometrial tissue is and where it's supposed to be located, which is inside of the uterus, now let's talk about endometriosis, where endometrial tissue is found outside of the uterus. So in endometriosis, those endometrial cells, they've gotten bored. They want to travel, see the world, or at least the rest of the body. So now we have these ectopic endometrial cells that are implanting themselves in random places throughout the body. And because those ectopic endometrial cells have the same programming as the ones inside of the uterus, they undergo the same cyclic changes each month, which causes inflammation, scarring, adhesions, bleeding, and a number of other problems we'll go over shortly. So again, endometriosis is endometrial tissue occurring outside the uterine cavity. It seems like such a simple thing to commit to memory, but when you're taking your exam and have a million other things to memorize, you might forget it. So what's an easy way to remember that? Well, I want you to remember, instead of endometriosis, remember endometriosis, as in meat like steak and tree like a tree with branches and leaves. So when you see the word endometriosis, think of endometriosis, and I want you to picture a tree with meat on it. Literally a meat tree with meat hanging from its branches. And when you think of this ridiculous tree, I want you to think of exactly what you would think of in real life, which is, why is there meat hanging from this tree? That's not where meat is supposed to be found. And then you'll remember that's exactly what endometriosis is, meat or tissue where it's not supposed to be found. So remember, endometriosis, meat hanging from a tree, not where it's supposed to be found. And then you'll remember that endometriosis is endometrial tissue where it's not supposed to be found, outside of the uterine cavity. So where can we find these adventurous ectopic endometrial cells? Well, all over the body, really. The bowel, the bladder, posterior broad ligaments, even the diaphragm and pleural cavity up in the lungs. These lesions typically, though, will be found within the pelvis, and the most common site specifically of endometriosis, and the one you need to know for the exam, that's the ovaries. Ovaries are the most common site for endometriosis, so you have to remember that. Now, why does this happen? Why are these endometrial cells being found outside of their home base? Well, we're not 100% certain, and there's many proposed theories, but no single theory explains all of the cases we see in patients. But we know it's likely multifactorial, so a lot of different things contributing to the cause of this disease: genetic factors, altered immunity, imbalanced cell proliferation, and apoptosis. And while there's many proposed theories for the development of endometriosis, there's only one I'm going to mention because it's the current most accepted theory, and that's the theory of retrograde menstruation, or Sampson's theory of retrograde menstruation, named after the doctor who came up with it, Dr. Sampson. So the thought is, during menstruation in some women, rather than endometrial cells flowing forward out of the body as intended, endometrial cells are actually flowing backwards through the fallopian tubes and into the peritoneal cavity during menses, which can result in endometrial cells implanting themselves in different areas where they ain't supposed to be. This sounds very simple, but the problem with this theory is that we've come to realize that retrograde menstruation, it's actually really common. Around 90% of women have retrograde menstruation, but only around 10% of women are actually developing endometriosis. So while we know this may be a contributing factor, we know there's other factors that are involved that make some women susceptible and others not. Some women are just flushing out these ectopic cells, and then others are actually having them implant. So we know this has some part of the reason why some women develop this. We just know there's other factors. All right, next let's talk about the risk factors. Okay, so starting with family history, nulliparity, so women having no previous births, early menarche, heavy menstrual bleeding, women who've had a history of obstruction of menstrual outflow, so in things such as cervical stenosis, among other factors. All right, let's move on to clinical manifestations. Very important to know how this presents. So patients with endometriosis are found to have increased production of pain and inflammatory mediators. These ectopic endometrial cells have the same estrogen receptors as endometrial tissue found within the uterus, so they'll actually undergo the same cyclic changes each month, causing inflammation, pain, bleeding, etc. And where these women are going to have pain all depends on where those ectopic endometrial implants are located in the body. But with that being said, let's talk about the most common presenting symptoms and how you'll likely see it on your exam. So a major component of endometriosis is pain. So abdominal or pelvic pain is quite common. This can be described as dull, throbbing, sharp, or burning. Dysmenorrhea or painful menstruation. This can be quite severe in some women. Dyspareunia, which is pain with sexual intercourse. This is more suggestive of peritoneal lesions or deep endometriosis lesions. Dyschezia, which is difficulty or pain with defecation. You'll see this in women with bowel endometriosis. These women may also complain of diarrhea, constipation, or bowel cramping. Heavy menstrual bleeding, as well as infertility. So we're not exactly sure why endometriosis causes infertility, but it's believed to be related to the chronic inflammation associated with this condition. The inflammation is believed to impair ovarian and endometrial function. It can be damaging to sperm, and more advanced disease can lead to adhesions and distortion of pelvic anatomy, all of which can negatively impact a patient's ability to get pregnant. So there's a number of other possible symptoms: urinary frequency, urgency, painful micturition. Some patients may have chest pain, hemoptysis. Some patients may be even asymptomatic, and sometimes it's just an incidental finding on imaging. So there's a number of clinical manifestations, but if we're going by what's most common, what you'll likely be tested on and what I was tested on, it's really four things. And that's going to be dysmenorrhea, dyspareunia, dyschezia, and infertility. They will almost certainly give you a patient in their reproductive years having trouble getting pregnant, complaining of severe pain with menses, pain with defecation and intercourse. So how can you remember that? Well, whenever you see endometriosis, I want you to think of furry men eating cheesy pears. Furry men eating cheesy pears, very weird picture to paint in your head, that's why you'll remember it. So furry helps you remember infertility, men helps you remember dysmenorrhea, cheesy helps you remember dyschezia or Dyschezia as it's spelled out and how I used to pronounce it, and pear helps you remember Dyspareunia. So think back to your meat tree and now just picture some cheesy pears hanging off the branches with these furry guys picking them off to eat them. So furry men eating cheesy pears, that's your clinical manifestations. Next, let's talk about physical exam findings. So physical exam is going to be different for each patient depending on the location and size of the lesions. And some women may have a completely normal physical exam, which in no way rules out the disease. But if a patient does have positive physical exam findings, what should you be looking for? Focal tenderness on vaginal exam, nodules in the posterior fornix, adnexal masses. Adnexal mass, if you're not familiar with the term, just means a mass of the ovary, fallopian tube, or the surrounding area. Immobility, fixed or lateral placement of the cervix or uterus. Sometimes you may also hear of the uterus being retroverted as well. So just some general things to be aware of. But again, this isn't the highest yield thing to know about this because many women may have a completely normal physical exam. Let's talk about diagnosis next. So diagnosis, the only way to definitively diagnose endometriosis is with a surgical biopsy. Going in, cutting out some tissue, sending it off to the lab. This is obviously quite invasive. So the alternative to this is to make a clinical diagnosis. So a presumptive clinical diagnosis is based on the symptoms, signs, and imaging findings. So you have a patient who has the furry men eating cheesy pear symptoms. They may also have some of the typical physical exam findings we went over. Ultrasound can also be utilized and is typically the first line modality when imaging is indicated. And what it may show is something known as a endometrioma or a chocolate cyst. Endometrioma is a cystic mass arising from ectopic endometrial tissue. This is usually in the ovaries. And you'll sometimes hear it being referred to as a chocolate cyst because it contains this thick brown tar-like fluid or old blood, so chocolate in appearance, I suppose. MRI is another imaging modality that may be utilized in some patients, although ultrasound is usually favored as it's cheaper and it's available at most facilities, and the sensitivity and specificity are similar between the two. So those are the components of a clinical diagnosis: signs, symptoms, and imaging findings. And a clinical diagnosis would be appropriate for a patient with mild to moderate symptoms, a patient who you're going to treat with lower risk meds like NSAIDs, hormonal contraceptives. But what I think you should remember for the exam is how you make your definitive diagnosis, because they love to ask you, how do you make a definitive diagnosis for a disease? And the way you do that, as we went over before, is with a laparoscopy and biopsy. This is what they're going to ask you on the exam: how do you make a definitive diagnosis for endometriosis? And you do that with laparoscopy and biopsy, which involves a small incision, throwing some cameras in the abdomen, finding a suspicious lesion, and sending it off for biopsy and confirming it indeed was an endometrial gland or stroma outside of the uterine cavity. Laparoscopy can also serve as both a diagnostic and therapeutic tool, as when the lesions are visualized, they can also be removed, improving the pain for some women. So this is obviously going to be much more invasive than a clinical diagnosis, and it's only really going to be reserved for patients with more severe pain, patients who are not responding to some of those first-line meds that we'll go over shortly, as well as some other indications. So again, for the diagnosis, you can make a clinical diagnosis based on signs, symptoms, imaging findings. Remember, ultrasound if you do need imaging, but if you want to make a definitive diagnosis, that's done surgically through laparoscopy and biopsy. All right, so treatment. Treatment of endometriosis related pain. We can manage this with medication or with surgery. Let's start with the meds. There's a few different meds and classes: hormonal contraceptives, NSAIDs, GNRH analogues, Danazol. There really isn't any compelling data to suggest one class over another based on efficacy, as they all have been found to have relative similar clinical efficacy for reduction of pain. But with that being said, as efficacy is similar between the classes, your first-line meds are going to be based on cost, availability, side effect profile, etc. So in women with mild to moderate pain, your first-line treatment is generally going to be with your combined estrogen, progestin contraceptives. These are going to be your first-line treatment for most women with endometriosis-related pain. Continuous regimens are found to be more effective at reducing pain than cyclic regimens, so no hormone-free intervals during the month. So why do we start with this class if we don't have compelling data to suggest one class over another regarding how effective they are? This is because contraceptives, compared to some of the other meds, are cheap, they're pretty well tolerated, and importantly, they can be used long-term, whereas most of the other classes we'll go over do not possess these characteristics. So the combined contraceptives are thought to reduce pain and disease activity through suppression of ovarian function, causing atrophy of endometrial tissue. And of all of the treatments for endometriosis, if you're going to remember just one, this is the one I would say to focus on. And if a woman is unable to take combined contraceptives, progestin-only therapy is an alternative. All right, next let's talk about NSAIDs. So NSAIDs, they're technically still considered as one of the first-line treatment options for endometriosis-related pain. This is from the ACOG guidelines and up to date. And it's really for some of the same reasons that we use contraceptives. They're low cost, readily available. So often these will be used in combination with contraceptives. But what you need to keep in mind is for NSAIDs, there's not actually any high quality data to support their use. We know they work well for other forms of pelvic pain. They're effective for primary dysmenorrhea, but the data to prove their efficacy in endometriosis related pain is just not there. But we just use them, like I said, because they're cheap, they're readily available, but there just really isn't any data supporting that. But with that being said, a lot of the major guidelines still suggest them as a first-line med. All right, let's talk about our GNRH analogues next. This is another important treatment option, your GNRH analogues. So that's your gonadotropin-releasing hormone analogues. GNRH analogues include your agonists like leprolide, and then your GNRH antagonists like elagolix. These meds downregulate the pituitary-ovarian axis, decreasing estrogen, which ultimately induces amenorrhea and endometrial atrophy, leading to improvement in pain. They're usually not first line and not due to lack of efficacy, but more due to the fact that there's more side effects and limitations on long-term use. They can cause hypoestrogenic side effects like decreased libido, mood swings, headache, decreased bone density. And to reduce these side effects, there's something called add-back therapy. And this is where you add back hormones, usually progestin. There's some other options too. And this improves some of those hypoestrogenic side effects. So again, this class is no less effective than our contraceptives, but due to these side effects, as well as limitation with how long these meds can safely be used for, which is generally 6 to 12 months. For this reason, they're usually second-line meds and more reserved for patients with severe symptoms or patients refractory to your first-line agents. And next we have Danazol. So Danazol is an androgenic drug that actually works really well. The problem with Danazol is the side effect profile. It's not very good. Acne, edema, weight gain, hirsutism, voice deepening, myalgias. So we don't use it often due to this. There's some other treatment options, neuropathic pain treatments, aromatase inhibitors, which are used off-label for refractory cases. But the ones I went over, that's the one you should focus on for your meds, really focusing in on those combined contraceptives. Let's talk about surgery next. So surgery is obviously more invasive, more expensive, can be associated with complications. So surgery is going to be reserved for patients who have tried and failed meds, patients with contraindications to meds, patients with obstructions of the urinary or GI tract. There's two main options for surgery, your conservative approach and then your more definitive and invasive approach with hysterectomy. So let's start with the conservative approach, and that's with a laparoscopic excision and or ablation. Now, this is usually the first-line surgical option because this procedure preserves fertility and hormone production. It's less invasive than a hysterectomy, so this is usually where you'll start with your surgical options. So the same laparoscopy we discussed before being used as a diagnostic tool to make a definitive diagnosis, while it can also be therapeutic. When they go in, they're obtaining tissue for biopsy. They can remove the suspicious lesions to improve the patient's symptoms. The problem is, while there is typically significant pain relief after the procedure, pain recurrence is fairly common. So in women with debilitating symptoms, who have no plans for future childbearing, and who have failed both medical therapy and conservative surgical therapy, these women would be candidates for a hysterectomy with or without oophorectomy. This is obviously last line treatment as it's much more invasive and obviously due to loss of fertility with this type of surgery, but it can be a definitive option for some patients. So a quick bit of info about the with or without oophorectomy part. If you're doing the hysterectomy anyways, you're removing the uterus, why not just remove the ovaries in all women, which would likely increase the efficacy of the surgery? Well, in premenopausal women, once you remove the ovaries, menopause begins. So you induce premature menopause, meaning all of the symptoms and risks associated with menopause begin. So if this is an older woman that's close to menopause anyways, hysterectomy with oophorectomy would be appropriate. Or if a woman has extensive disease involving the ovaries, oophorectomy would also be appropriate. But this is obviously going to be a case-by-case basis depending on the patient involved. So that's endometriosis. There's a lot to know. Let's do a 30-second recap of the highlights. Then let's talk about a mnemonic to help you remember all of the highest yield points. So endometriosis, what is it? It's endometrial tissue outside of the uterus. Where is it most commonly found? That's going to be the ovaries. How's your patient going to present? Furry men eating cheesy pears. How do you definitively diagnose? Cut it out and biopsy. What's your first line med? Usually going to be contraceptives. This can often be combined with NSAIDs, and surgery is going to be reserved for severe or refractory cases. Now, what about the mnemonic? Well, back to the meat tree we talked about before, endometriosis. So all of the high yield points about endometriosis are in and around that meat tree. So every time you hear endometriosis, I want you to think of that meat tree we keep talking about, a tree with meat hanging from its branches. As you remember, that's not where meat's supposed to be found, which will help you remember what endometriosis is, meat or tissue, endometrial tissue specifically where it's not supposed to be found. Next to that meat tree, there's some furry men hanging out and they're snacking on some cheesy pears they pulled off the tree. That helps you remember the common clinical manifestations you'll likely find in the vignette, which is infertility, furry, dysmenorrhea, men, Dyschezia or Dyschezia, cheesy, and Dyspareunia, pears. Next, on the trunk of the tree, like any cartoon tree you've ever seen before, there's always that little oval hole on the trunk with a bird or squirrel hanging out in it. So on our tree, on the trunk, there's a small oval opening. And oval helps you remember ovaries are the most common area to be affected. And then in that oval, there's a bird hanging out in the hole to help you remember birth control, aka contraceptives, which is the first line meds, birth control. So endometriosis, meat hanging from a tree, bunch of furry men hanging out around the tree eating cheesy pears, oval hole at the bottom of the trunk of the tree with a bird hanging out of it, and that's endometriosis. Let's do a few quick questions to test your knowledge. Question 1. A 32-year-old nulliparous woman complains of dysmenorrhea that has become progressively worse over the past few years. She also reports experiencing difficult, painful defecation, Dyschezia, and painful sexual intercourse, Dyspareunia. Patient and her partner have been trying unsuccessfully to conceive for the last year. She has tried over-the-counter NSAIDs for pain relief, but does not find them to be very effective. Upon pelvic examination, focal tenderness and immobility of the uterus is noted. A presumptive clinical diagnosis of endometriosis is made. Her primary goal is pain management, and as she is not planning to conceive at this time. In the absence of contraindications, which of the following medications would be the most appropriate option to try next? A. Combined contraceptive. B. GNRH agonist. C. Danazol. Or D. GNRH antagonist. So that is going to be, give you a few seconds here, A. Combined contraceptive. So we have a classic presentation for endometriosis. We have a patient with dysmenorrhea, infertility, Dyschezia, Dyspareunia. So the furry men eating cheesy pear symptoms we went over earlier. On physical exam, you have focal tenderness, a fixed uterus. We see she's tried NSAIDs with minimal pain relief. So which medication class would be appropriate to try next? Well, right off the bat, we can eliminate Danazol. As we discussed before, it has a lot of side effects. It's not going to be a first-line med. So we're left with contraceptives and our GNRH analogs. And while they both have similar efficacy, we know we usually start with contraceptives due to the more favorable side effect profile and the ability to use these medications long-term compared to GNRH analogs, which are limited to 6 to 12 months and require add-back therapy to combat the hypoestrogenic side effects we talked about earlier. Question 2. In order to establish a definitive diagnosis for the patient described above, which of the following diagnostic procedures would be the most appropriate choice? A. Laparoscopy with biopsy. B. Ultrasound. C. Magnetic resonance imaging, MRI. Or D. Computed tomography, CT. So I'll give you a second. That is going to be A. Laparoscopy with biopsy. So remember, the only way to definitively diagnose endometriosis is with tissue biopsy, which is typically obtained during laparoscopic surgery. So locating, cutting out the tissue, and sending it off to the lab. MRI and ultrasound can be utilized in the initial workup, but will not provide a definitive diagnosis. And CT is generally not utilized in the diagnostic workup due to exposure of ionizing radiation of the patient, as well as low test sensitivity. Question 3, laparoscopy with biopsy is performed on the patient described above, confirming the diagnosis of endometriosis. The provider informs the patient that the endometrial lesions found were located in the most common site for endometriosis. What area of the body would the provider likely be referring to? So I'll give you a second. That is going to be the ovaries. So the ovaries are the most common site for endometriosis, seen in up to 67% of women with this condition. All right, so that is endometriosis. I hope that was helpful. Thank you as always. If you don't mind, if you're enjoying the video, if you could like the video, leave a comment. It really helps just spread the word about the channel. And thank you so much as always for watching.